thank you, and thank you for inviting me and also the rest of the team at Experio, because they are, of course, with me to some extent at least. I'm thinking maybe I should start, since most of us are Scandinavian or maybe even Swedish, or not all of us, so maybe sort of just a quick look at Swedish healthcare, so you know sort of the background on why we are doing the things that we are doing. In Sweden, we only more or less have public healthcare. And I am a civil servant employed by the public healthcare system, a county council. The county council, we have about 7,000 employees and a few hospitals and primary care centers. That's what we run. So I work directly in the healthcare organization. And I guess for the ones that are Swedish, you know that Swedish healthcare, we are top quality, but there are also a big problem right now because we have a shortage of resources. It's not going very well. Most county councils and healthcare organizations are in deep shit money-wise, to be fair. So we need to do something. We need to add another resource. And actually that's also in the law, because we have a patient law. The resource that we need to add if we're going to afford, because it's going to be even more expensive in the future. We have a demographic situation where we get older. The digital world will make us as patients more skilled and trained and expect other things from healthcare than we deliver today. So the shortage of resources, the money problem in Swedish healthcare is not going to decrease. It's going to get worse, a lot worse. So again, we need to add a resource. And the resource is us. It's you. It's all of us. That's what most county councils are looking to. How do we add and take care of the resource of us as patients? And that can be different things. It could be in the extreme way that we actually do medical procedures ourselves. We have not been a part, but for me it's a good example. For instance, in Swedish hospitals, if you need to do dialysis, I think it's called in English, you can actually be trained as a patient, so you can go to the hospital and do that on your own, without any staff being there. It can even be that if I would need that, and I should be speaking here, I could book myself at a hospital here and go there and start a machine and set the needles and change my blood before I went on stage here. So for me, that suggests there are lots of other things that medical procedures that we actually can do on our own if we get the possibility to do it. And it will also probably create opportunities for us to have value in our life if we do it in the right way. Adding the resource of patients could also be being part of sort of the service, in the sense that we book our own times or find knowledge, get information on our own, use that type of services. And they are not really very good developed in Sweden, as the Swedish people know. So that's another way that we can add the resource. And of course, we could also add the resource of patients as far as we can look into innovation or service innovation. How do we actually produce healthcare in the future? Should it only be hospitals, or should we do it somewhere else? Should we use internet, or should we be in people's homes, or what other type of services should it be in the future? So we could add patients also in that process. So that's the background. This is a problem, I think, for most healthcare organizations. How do we take care of the resource of patients? How do we make them a part of what we do? And our county council in Värmland, West Sweden, where I live, we have decided to start an innovation hub or a design lab, or whatever word you want to use, called Experio Lab. So that's the county council's innovation platform. And we have chosen a specific tool or method in our approach, and that is to use design. Because that's the way we think, that's the best way we think to actually both involve the patients in how we innovate, but it's also a very good way in building the culture and actually involving both staff and patients in joint projects. Because for us, if we're going to achieving that goal in implementing that resource, it also means that we have to change the culture of the system. We need to train. It's not going to be the designers that come into it, and a healthcare organization cannot take 300 designers on board, but we can train the skills of the nurses and the doctors to, on an everyday basis, be more trained and skilled and be more efficient in involving the patients in what they do. So that's how we started, and so Experio has now 2 years running. And Johanna, she asked me to come and present one of the projects. This is just a short background. We try to have a philosophy to all our projects. Sort of this is maybe our design method, if you want to call it that. So all projects that we go into and support is built around curiosity and empathy for the people, for the patients, or for people's life. We have to be courageous, so we train staff to be courageous and talk about it with managers, that if something happens, you have to have the courage to actually change things. And you also have to be courageous in the sense that you can actually, because if you have a very old system like healthcare, which is very sort of rigid and old, it also takes courage to actually think there will be another way to do it. It's not that easy. So we talk a lot about to have the courage. And we also talk about it's not going to be one person, it's not going to be the designer, not the engineer, not the patient, not the doctor that's going to solve it. We need to collaborate, and we need to do co-creative projects and use the team if we're going to solve the situation for the future. So, sorry, too fast. Can I go back? Yeah. The project that Johanna asked me to present was actually one of our first that we did when we started up. We call it the Patient Journey Project. And as you can see from the slides, we actually had a design agency helping us out down the line also, so that's why they're on there. The Patient Journey Project we choose to do that for 2 reasons. Our county council, they wanted to understand an entire journey from the patient. Because now we are divided into, what do you call it? What's it called in English? Silos. So we wanted to understand sort of the gaps between the silos in the system, and by actually finding sort of from where a need was arrived to when there was no need anymore, and how does that process work? That was the goal of the project, but we had sort of a sub-goal in saying, okay, we also want to train the skills and abilities of nurses and doctors to be able to do that on a more everyday basis. So this is where we started. This was some sort of brief, maybe. We knew from start on that the system is disjointed and ineffective. We know that the patient's experience is not good enough. There is high cost of transferring, and it's a poor utilization of resources. We know that the highest cost in healthcare is actually when we transport patients. The most sort of injuries and costs is in between the silos. That's where it doesn't work. And this is how we did the project. We invited 28 stakeholders or staff. They were both from, again, this is Swedish context. It was both from the county council, from the hospital, but also from the municipality, because most of we had a focus on elderly people, and they are taken care of in their homes by the municipality, and then if you're ill, you go into the hospital. So, but we had staff from both sides, and it's with nurses and doctors and other people, lots of people involved, 28 of them. And we chose 3 real cases. Liv, Inge, and Ove. Again, this is maybe just for the Swedish audience, but I work for the County Council of Värmland, which is in Swedish is Landstinget i Värmland. Liv is our sort of, will be short for it. So if you turn the word, it was a little bit, yeah, I know people from Gothenburg, so then you can read, there's no life for Ove. That's why we called that. Yeah, silly. But you need to be silly sometimes. So we took 3 actually real proper patient journeys, and we decoded them a little bit, and we gave personas and gave them names, and then we role played them. So, see what's on the. Oh, sorry, too quick. I go back to this picture. So what we did was we role played those 3 patient journeys. We gave one person the role of being the patient, and we gave the other staff other roles, like the photographer taking photographs. We had someone doing interviews with the patient. We had someone doing interviews with the staff that received them, because we did all this in we did it in real context. So if we needed to go in an ambulance, we went in an ambulance. If we needed to do an operation, we actually undressed and cleaned and set the needles on people. To make it as real as possible, we actually used tape. So we didn't set the needles, but more or less. So because we wanted to do everything in real context, which meant that we also could interview and ask the receiving staff to get their experiences. I'll get back to that. We also used stop-motion cameras that we put on the stomach of the person playing the patient. And then this is what you get. I want to be secure, so she has the crutch in front of her all the time. I showed us this little clip because just to sort of give a glimpse on the different, again, think of that you are in a healthcare organization working on how to improve it. Normally you will have lots and lots and lots of information and stats. But in this case, we could give them some other material to actually act upon and use their experiences and their feelings and an understanding of the patient. So that's why we did material like this, and saying it was sort of an exact patient journey. So we role played it over a few weeks. We divided the journey into 3 parts. So we started up with a workshop, sort of preparing everyone on what to do and train them a little bit. And then we did the first part of the journey from a person's home into the hospital situation. And then after that, we had a workshop that we tried to sort of gather all the information, the interviews, the photography, everything that we sort of have collected. And then we did the next part of the journey that was inside the hospital, and then we stopped again and had another workshop. And then we did the last part of the journey. And then again, a big workshop afterwards to collect and find things. And this is type of tools that was used in the workshops. Here we have like an emotional mapping of journeys from patients, what were the experience they had. So in the top, you have sort of what it felt to be the patient, and then you have the emotions in the middle, and the organizational level in the bottom. So they mapped that out and found things like when they were the patients, they felt like I was moved around based on the care center's needs and resources, not on my personal needs. So the silos were more important than me. I felt I was not a real person, or I wanted to be a real person, but I was treated as an object. I felt that I didn't want to be a burden to the system, so therefore I was a little bit shy. When they looked at the organizational point of view, they found things like, okay, we collect shitload of data, but we don't know what we collect it for. And in all the silos, we collect the same data, and we have no idea on why we do it. So, and again, the organization is not set up for collaboration, so all the silos will do the same thing. We had one staff member playing the patient that in one of the workshops was so annoyed on that. I don't know, she said something like, I wonder if they think I'm just plain fucking stupid, or if they do it to control me, but now I gave the story on my situation to 8 different people. Is that really necessary? And again, this is a nurse that says that. So, of course, stepping out of your professional role and play the patient is a powerful way to gain insights on what to change. And you can listen to what Ulla says.
When we started this journey, I thought, oh my God, 8 weeks of meetings every Friday morning. During the journey, I started to look forward to the Fridays. I've been surprised by my own feelings. I got to play the patient. I've been a nurse for 40 years, so I thought I knew what the patient needs, feels, or wants to experience, or how to treat them. And suddenly, when I put my non-seeing eyeglasses on, I became this old man Ove. Mostly I realized I was quite alone during the journey. I didn't feel safe. Which reminds me, when I work, to make sure that my patient is safe. It also made me realize that we talk about patient in center. In centrum, we are to look at things from the patient's point of view. We don't do that. The patient is there, being transported around, and sometimes it feels like we have more respect for the doctors than for the patient. If somebody had told me this, it would have been, okay, another 15 minutes to go, and I know this, I've been here for 40 years. I think I know this. And if somebody had told me you don't know it, I might have been offended. But this came as a surprise, and I really had to put myself into the woman's position. And also, I think everybody should go through this journey.
The sad thing, or I don't know if it's sad, because I think it's good for Ulla, but she actually changed job afterwards. She's still a nurse, but she doesn't work for the County Council anymore, because she couldn't take it. Another thing with Ulla is that I actually brought her, because last year we did a presentation at Service Design Global Conference that was in Stockholm last year, and I brought Ulla there, and people said, I want to bottle you and bring you home. And she's worth it. She should have been her, but basically was here. So let's see, what happens? Okay. Do you recognize the persons, the Swedish people in the audience to the upper left-hand corner? Yeah, the social, what do we call, Minister for Social Affairs in Sweden. When we opened Experio Lab, he happened to be there, so we made him do the journey. We wanted him to be the patient, but he was scared that we would take picture of him in his underwear. So we couldn't do that. We had to make him into a doctor. And the other person was at that time our top manager. He's now at top manager on the national level for Swedish healthcare. And he's a really good actor. But if you're going to do something like we did there and open a thing like an Experio Lab somewhere else, you should not have a manager like him being as a good actor as he is and role play it during lunchtime where there's about 300-400 people in the canteen. because when he got ill, we had to seduce him because he broke his leg. And so what we did, we drove up an ambulance to the main entrance of the County Council administration house, where there's 300 people working, with full sirens on, and then we carried him out on a stretcher, and he was really gone. So people thought he died. Okay, so what happened in the project is that I think we managed, first of all, for the 28 participants, but also by the staff receiving them, we managed to build empathy. I think we trained them, we gave them skills, like Ulla describes, to actually every day be a little bit better on focusing and understanding the patients. So again, it was just not the patient journey, it was actually an inner journey for the staff taking part of the project. We know that we built a better understanding for both the management, but also for the people in the project on the entire ecosystem of how the system works, because neither actually have visited the other silos in the system. An interesting thing is that we saw that since we had organized it in the way we did, people were able to step out of their professional roles and actually give critique to each other in another way than you normally do, because you were sort of out of context and can look aside from the normal hierarchy of things. So the nurse can give critique to a doctor, for instance, which they normally cannot. We were able to give to management targets and insights for change on the longer term, and I will give you a little examples of that in a while. And the fun thing is that we know that people that were part of the project now are doing other things together. We know it builds bridges between the silos, so they can actually call and do stuff together, or they can understand each other in a better way. So we know we built bridges. And first of all, which is not so very common in a healthcare organization, that we were able to have a little bit of fun while changing it, which is very, very important, I think. And if we look to this is what, of course, there were other things happening at the same time, but this project was a part of it. So this is actually from my county council's managerial, what do you call it, like a white paper thing, and how we want to change. So we want to go from having or had a focus on specialties to go towards flows. We want to go from the silos to a more collaborative work practice. We have been organized around resources where we instead should be organized around people's needs. And I think this is a case for many, many public organizations and even companies, that we tend to organize ourselves around the resource we have rather than the needs of the consumer, patient, or wherever, which I think is a little bit odd and strange. Since, especially in healthcare, who is creating the value of healthcare? Patients, exactly. It's us. It's we that live our lives. The outcome of healthcare is us being more healthy, or being able to go home and play with our kids, or have a longer and better life. So the value of healthcare is released by us. The organization has nothing to do with it. The only purpose of the organization is helping us to create the value. That goes not only for healthcare, that's an insight for others as well, I think. The only purpose of the organization is to help your customer, client, whatever, to create the value that they want to have. That's the only purpose. You will never create the value on your own. Go from coworkers first to patients first. Go from adding resources to rather using resources that is already there. We think we have a shortage of resources, but actually our county council, even though we're doing badly, we still have, what is it, like 7 billion Swedish kroners? What is 7 miljarder in English? 7 billion kroners, so quite a lot of money. So of course there is money and resources there if we just sort of reorganize them a little bit. not saying, okay, I want to change something, give me 1 million kronor and I will change it. It doesn't work like that. We need to go from lowering costs to rather decreasing waste. And we need to refocus from budget to quality. So the project sort of gave input to doing that transformation, or trying to do the transformation. We haven't done it yet. Okay. That was the project. I can give you a list of other things that we have done afterwards. One of the things that we felt during this project is that, okay, we should do something in every project that we are doing. So we developed what we call empathy tools. Some of you that have been in comfort with us, like Johanna, she has tried a few of them. They are maybe just playful, but it is a thing we try to do, especially with staff when we go into projects, just to give them a reminder of the experience of patients. So here we have our current top manager, CIO of the County Council, where we are trying to make her into an elderly person. So we put weights on her, we have foggy glasses and earbuds and stuff on her, so she can, for an hour, have the experience of being a stroke patient, for instance. Or we do stuff like this. This is a project that we did around people with a lung disease. So we made the staff, we made an easy sort of prototype thing where we mounted a straw to, yeah, you can see in the picture. And then I think she's actually reading the bus table because we sent them into the city to act and experience how it is to at least give some sort of impression on what it is to live with a lung disease before the project. So it makes it easier for them to be empathic and have an understanding of the situation for the patient. So we very often do that before we start the project. Or it could be this is one of my closest colleagues. His name is Per. And he was a middleman in the patient journey project, and he got the really fun task of running a project. So we got the project maybe then around, see if I can put that into English. When you do analysis, what is called like you take samples from bodies and analyze them. So you are somewhere in the hospital and you will take bodies things and then send them away. And then you will have to wait for several weeks, and then you will find out that me as a man, I have 2 wounds, and strange things happen. It goes wrong all the time. And it costs shitload of money. And we have a high percentage of faults in that system. And it's not only my county council, it's in every county council. It doesn't really work. So we got the task a little bit sort of using the experience from the patient journey project. How can we find the faults in that system? Is it the culture thing? Is it organized in the wrong way? So of course we did it in the same way. So this is the start of the project. Again, we need to do it using our, because again, for me that has to do something with design, or very much with design. Designers or people that have designerly skills are trained to use all bodily senses to experience situations and problems, which gives us an insight on how to run innovation and change things, which is very often in organization disregarded today. Thank you. So what we do very often in the projects is that we do projects in the way that we use all bodily senses to experience and gather information to understand the problem. So instead, to look to the pre-analysis phase and where it goes wrong by reading stats, we actually try to be the test tube. So Per Harris, he's starting off the journey by being in a diaconalist, what is it called? Yeah, thank you. And then he moved forward, trying to be the test tube and interviewing people and saying questions like, how do you handle me? What will you do with me now? Trying to understand the journey of the test tube. And now I'm going to show you a picture that I've never shown in public before, because we only use it for ourselves. This is our this is our own image that we use to remind ourselves on why we go to work, saying, okay, healthcare system and doctors and nurses, if you don't involve us and make it better for us, this is what we will do to you. So we use it like a symbol for not participative and not user-centered, not patient-centered healthcare services. We brand them with her. That's all. Thank you.
Thank you so much, Tomas. I just want to say that if you want to take one of these experiments home, I think there are some more cases on your website as well, especially if you read Swedish. But you can take a big straw like that.
We have one in English.
Yes, of course. But maybe there's more. Anyway, you can breathe through that straw. I have a grandfather who has, I had to look it up what it is in English, called chronic obstructive pulmonary disease. And I often feel that he should go out and get a walk and maybe exercise more. I spent 30 seconds breathing through that straw, and when I understand how little oxygen he operates on, this has completely changed my emotional attitude to who is responsible for him being stuck in his apartment. And that is an enormous change that you did in my life in 30 seconds, you know. So that's one that I recommend for everybody. Also, non-seeing glasses, you can make some with tape. Yeah.
Yeah, and just the reminder for me, because for me that is really important, since you are many of designers, that is also around building the capacity of the nurses and doctors to do it. It's not going to be you, but you have to help them. That's important.
Tomas Edman.
Thank you.